interesting question to ask is, Ted, if you had to do this all over again, knowing the possible consequences that now prevail on you, would you do it again?
And you would say?
Absolutely.
Well, my name's Donald Reid. I'm a vascular surgeon in Scotland. And I first heard of Dr. Dietrich when I was aged 4. My father, also a vascular surgeon, had visited Dr. DeBakey in Houston, Texas. And when he came home, he told me about this young surgeon who he regarded as the best technical surgeon amongst Dr. DeBakey's staff. I was very lucky to get to work with Dr. Dietrich in 1995 as a cardiovascular fellow. I was around for almost 2,000 cases, and so you become close with somebody who's trying to do new things and sharing the excitement of all of this together. One day, I was on holiday with my family, and on my mobile phone, all of a sudden, it is Dr. Dietrich. And to my horror, he said, "Donald, I've got a brain tumor. What do I do?" And the reason he was asking me this was because my brother Alan had had exactly the same thing. My brother Alan was the head of department as radiologist in Glasgow Royal Infirmary, and he had been pioneering all of the endovascular work, so his head was very close to the beam. Alan was extremely hardworking. He did many, many cases, and I would say he was meticulously careful with radiation. Dr. Dietrich and Alan collaborated a lot over the years in their own symptoms and treatments and what to do next and how to cope with it all. But it was terrible. It was awful. I remember having a horrible feeling having to phone Dr. Dietrich to tell him that Alan had died. Both Ted Dietrich and Alan were indestructible. I think both of them felt that they could beat this. And yet, if it could happen to them, it could happen to anybody.
I'll tell you, since 1869, things have changed in college football.
I often use the example of football players and chronic traumatic encephalopathy, or CTE. They play football and fans are yelling and screaming for them. They don't understand that by cracking helmets all these years, that they are sustaining irreversible brain damage. The same is true in the cardiac catheterization laboratory. Our physicians, nurses, and techs don't really realize or think about the long-term damage that they are being exposed to.
You ever worry about it? No.
I've been doing it so long, I don't worry about it too much.
Yeah.
I mean, I try to protect myself as much as possible, but you know, when you've been doing it for so long, you don't really think about it.
But there's no effect from radiation when you're standing in a room. You don't know you're being radiated, and and it's not a priority because it's not something we can see, and it's not something you can tangibly grab, and so you don't always see the results of what the exposure does to people over time until, my old partner from back in York just had his, third back surgery, and, we've all got friends. One of our colleagues here at Emory's father was an interventional cardiologist and died of brain cancer. And, and I think you start to see these events, and sometimes you need, 20 or 30 years of bad safety and bad protection to recognize that these are what the long-term outcomes are potentially going to be. And I think that's when you start to get, the drive or the motivation for people to have awareness, and, awareness kind of breeds innovation and change.
In the 80s, you go to a ski resort in Colorado, nobody wore a helmet. Now, everybody wears a helmet. Doesn't mean you can't ski, doesn't mean you can't snowboard. You can do the same thing. We can do the same thing and do it safely.
Totally.
And now there's technology that you can do it without having to wear the lead.
There was a time where surgeons didn't wash their hands or put on gowns, right? Well, that changed, right? It's just what it is.
Honestly, I think we're our own worst enemies in this regard. So it's because it's our personal health. We don't take it seriously enough. In fact, I posted on Twitter last night, why is it that we all get excited when we hear a presentation and then we go back and we do very little about it? And there are tools that are out there. So for example, there are real-time radiation monitors. I bought them. I couldn't even get the faculty to use them.
Smoking cigarettes. You know, when you're young and you're healthy and you start smoking, you're immortal. Nothing's going to happen to you. And so you don't think about the consequences of tobacco. When you start doing these radiation related procedures, you don't think about it. You're immortal.
My solution to solving the radiation issue was to take my badge, and my dad was the chief radiation officer, radiation physicist, and I would put the badge in a drawer because
We all did that. That's what we did. We all did that.
yeah.
Who wears their badge?
I said, you know, when they came to me and said, you've had too much radiation, I'd say, well, what the hell do you think I'm going to do about it? You know, you think I'm going to quit doing cases? I put it in the drawer. I said, it won't be that much next month.
It's interesting that one of the biggest pushbacks, one of the biggest obstacles we faced when trying to heighten this awareness was that it takes another 10 minutes to set up one of these new radiation protection systems. It's remarkable to me that an individual who works in a hospital, a doctor or a nurse, would push back on radiation safety or put barriers or obstacles up to making the cath lab a safer place because it takes a little extra time. That has been one of the great frustrations in trying to raise this awareness. It's very difficult to get hospital administrators and hospital systems to think this way. It's very difficult to get managers in the hospital to understand this. Quite frankly, they're not the ones being exposed. They're not the ones being exposed to the adverse consequences of radiation in the workplace. They're not the ones wearing lead for 10 and 20 and 30 years, which leads to irreversible orthopedic injury. So like CTE in football, radiation has another similarity. No one wants to talk about it. We tried to talk to a physician whose hospital administration refused to purchase one of these new barrier systems. So he bought it with his own money. And to no one's surprise, they also refused to let him appear in this film.
Did you get the email chain and the text chain where it's like, David, I don't think I can fight this?
People are afraid of these topics.
I think it's a prime example of what it is we're up against.
There is no doubt. Listen.
An interventional cardiologist is willing to take the risk because they want to do the greater good. And I think that's incredibly admirable, and it's kind of a very unselfish individual that is willing to do that. But at the end, I think that society and hospitals in particular really owe it to the doctors to give them the safest environment possible for them to do their job.
I think it's the responsibility of the health systems that we work in to put you in the safest environment. And currently we're not, and there's better options out there. And what'll happen eventually will be the same thing that happened in the NFL. You'll have a group of people that have had orthopedic issues, or you'll have a group of people that have had cancers from the radiation, and you'll have a class action lawsuit.
I mean, I don't think the hospital administration would really want to hurt physicians on purpose. That's not, they won't do that. I don't believe anyone wants to hurt anyone. But when you have layers of what we call committees and subcommittees, the people that are in that committee, they think paper, number, not a human being. And therefore, as a physician that works in an institution, you just have to follow the rules and follow the process.
I don't want this to sound like we're a bunch of victims. I truly believe that we do have ownership of what we can and cannot do in the hospital, because at the end of the day, we are the players. This idea that the administrators don't want to support it or this or that or the other thing, I just don't, I don't truly buy into it, because there's always a critical impasse where you could say, look, if I cannot get the protection that I need in the lab, both physically and with ability to be safe from radiation, then we're not going to continue. And that's a failure of leadership, that we cannot accumulate that essence amongst leadership to just call it out.
We need to step up in our own individual institutions and say, hey, being exposed to radiation is not an acceptable situation. I really believe people are going to look back on this era and go, they were crazy.
We as a interventional community, we as the physician community really have to speak up and have to say that you guys have to protect us. You guys have to give us a safer work environment, because we're going to be doing this for all of our careers, and our careers may be dramatically limited, or our lives may be affected if you don't protect us. And I think that really the cardiologists haven't spoken up with a unified voice, and I think it's time to do that.
But we're at a crossroads, a divergence of incentives.
Yeah.
Hospitals dropping margins, dropping reimbursement, increasing the cost of providing a product. Serious. More than half the hospitals in America lost money, tons of money last year. So the idea that you're going to increase the cost of providing the service or the procedure with a declining reimbursement on the other end.
There just isn't any kind of financial incentive or reimbursement or motivation to protect us. And there's no reimbursement behind it. There's no reimbursement for the procedure if you use an added protective system, which I think there should be. I think if you're using adjunctive radiation shielding, I think the procedure should be reimbursed differently. I think it has dramatic effects on the safety of the staff, and it just has not been a priority, but I think it is becoming that.
The cost of the newer technologies relative to the cost of having one of your operators reduce cases, or one of your high-end operators come out of the lab for a year like I did, is astronomically different. Your most important resources are your human resources. And for maintaining staff, and I can tell you most of our staff, when they get into the 30, 40-year-old range, they leave. And a lot of it's because they can't take the stress and the strain of the lead aprons. So they go into other things, and you get new people in, and then you have to retrain. So your most experienced people are leaving really right when you're training them to do some of the most technically difficult, some of the most complex procedures that are being done anywhere in any hospital, in any operating room or cath lab. So you really want to maintain those. You want to keep those people in your lab throughout their entire career.
There was on Twitter last week one of our really experienced x-ray techs. The comment was, I've got this new radiation protection. I haven't worn lead for 6 months. And our tech put on Twitter said, that'd be great. I'd work another 5 years if I didn't have to wear lead.
I think the good hospitals, the hospitals that really are known for being able to take care of their doctors, will generate a lot of loyalty, and that will be good for business. So I think that you really have to understand that taking good care of your doctors in the long term is the best business practice you could have.
We're excited that we're going to be the first healthcare provider in Arizona to adopt this technology, but we know that these findings are really important for everybody to see, so that they can also embrace this. Your life's work is what has enabled that. So I wanted to say thank you for your life's work.
Are you willing to risk your life to save a 95-year-old?
Wow. Kenzie, does this sound familiar? Okay, great question. You know, the other day, we did an aortic valve replacement on a 95-year-old. Now, to me, that was extremely important. This 95-year-old is part of what Tom Brokaw called the greatest generation. To be able to give back to that generation of great Americans who sacrificed so much for this country. It's one of the greatest personal feelings that you as a physician can experience. However, in saving that 95-year-old, we exposed doctors, nurses, X-ray technologists to the potential harmful effects of radiation. And now there's a balancing act. We may cut the lives short or cause long-term consequences to young people in the name of saving a 95-year-old. And that's a very delicate balance. And that's why improving the safety of our environment here, so that's not part of the equation. So that's not part of the calculus. That's the most important thing we have to do. So what do we know? We know it's estimated that 1 in 25 of us high-volume operators will acquire a radiation-induced cancer, and 1 in 50 of us will die from such cancers. We know 60% of us will have debilitating orthopedic issues after a 20-year career, nearly 57% higher than the general public. Listen, I get it. Cancer can't be proven, and we need more research or some kind of self-reporting registry to track these occurrences. But I also know that I don't need a research study to tell me it's a good idea to wear a parachute when I jump out of a plane. We know there is a problem. We have solutions today. But the question is, do we really care?